Welcome to Connected by Health. I'm Dr. Krishna Vedala. This is where medicine meets leadership, innovation, and humanity with one goal: to add value and help change healthcare for the better. If you believe health is about more than a diagnosis, you're in the right place. Welcome back to Connected by Health. And folks, remember, this is your own podcast. Mental health is the foundation for how we think, how we feel, and how we navigate life's challenges, influencing our relationships, our work, and physical health. Therefore, prioritizing mental wellness reduces stress, improves resilience, and helps us lead more fulfilling lives. And today, we're fortunate to hear from an expert who brings compassion and evidence-based care to this vital field. Please join me in welcoming Dr. Crystal Hernandez. Dr. Hernandez is a forensic psychologist by training with an MBA and more than 20 years of experience in behavioral health, 15 of them actually in administration as a system architect and activator. She has the clinical training to read the patient and the MBA to read the business of the system. And that last word, activator, matters. She doesn't just design the fix on paper, she operationalizes it. She makes it happen. Her whole career has been about looking at how a system fits together, where it overlaps itself, where it leaks, and where the money and the effort get wasted. And then she helps building and standing up and making something better. She works at the exact seam where healthcare quietly tears, the line we've drawn between physical health and mental health. And of course, she also has an amazing book that's going to be coming out that we'll get into. Dr. Hernandez, welcome onto the show.
Thank you. Thank you for having me. I didn't come to this work from a textbook, I will tell you. I came to it from lived experience. I've been in the behavioral health industry, as you mentioned, for over 20 years now and trained as a forensic psychologist. Thought I was going to do my whole, life in that field, in that specific widget of the field. And then I started to really look at how the systems all work together. And for the last 15 of those 20 years or so, I've been working in administration as that architect, as you described, and looking at how we can activate things. And so one thing I just want to say that led me to this work, I lost my best friend to substance use disorder a few years back. And I want to be precise about how that happened because the mechanics of it is the whole argument. We didn't start on this journey with him with the, street use or anything like that. He started with a prescription, something a doctor gave him for a legitimate physical need. And what our system did next was really heartbreaking. There was no behavioral health provider anywhere in that loop, anywhere along his journey. Nobody was screening him for dependency or risk. When the warning signs were there was no warm handoffs or interventions done from that side because behavioral health was absent. And that's the piece that haunts me clinically. When we need to have the integration save lives, intervene alongside, and be a part of all those journeys. And so it's really about that cliff and that gap, and he fell off. And I want to make sure that there are a lot of people who are walking journeys in their health, care, dentistry, any of the above, where medications are prescribed, where there's these behavioral health, alongside journey pieces. And so that is really important in my introduction. And then the second piece of my introduction that I think is really important, along with that education, all that stuff, is I grew up as a child of, with a father who struggles with addiction. And he's still on his recovery journey today. And so I understand this from the inside out, not just as a chart or a number or someone in the distance. This is something that I grew up with and I, deal with not only professionally, but personally. And that living has taught me two things that sound like they're attention, but they're not. I believe in second chances and in opportunity. My father's life is proof that people can change. And I believe just as much in boundaries and in breaking cycles because love without structure doesn't heal anyone. And the patterns that run through these families and through families like mine, they need a system around them. One that actually interrupts the cycle and provides those opportunities, second chances and boundaries, accountability and opportunities. They're not all opposites. That's how a good system works. So I just thank you so much for having me on to be able to talk about all these things.
Well, we are really excited. We have quite a bit to cover today, ranging from integration of mental health. And also, of course, I also want to touch real quick about your book that's coming up. And so let's get started. Why is integrating mental health care into primary care and community health systems so important today? I know you just talked about your friend, but could you give us a little bit more an explanation as to why that's so important?
Well, I think no matter what you turn on, whether it's social media news, the news itself, you pick up a book, you pick up a journal article, log into social media, the need is staggering. And the way we currently meet it is the most expensive, least effective version. And we talk about limited resources. We talk about limited funding. We also have always talked about siloed care and all these limitations. But what we need to talk about is the Oklahoma numbers in particular, since this is an Oklahoma based podcast. Again, data is always what data is, a few years outdated, right? And so we know there's an overwhelming increase in the demand for mental health services in Oklahoma from little children all the way up to elderly. And if you look at, the data that's available, it's saying anywhere around 750,000 to 950,000 adults who are in need of mental health and substance use. Again, outdated data, but we know the increase is there, especially in our youth, especially in pockets that we haven't historically seen that growth and that need. So with all of that, knowledge, we know that this is now the time. It's beyond the time to have these critical conversations, be nimble and be vulnerable enough to say, you know what? The way we've been doing it is not working. Something is missing. And it's not that the efforts weren't great, and it's not that the providers aren't wonderful. It's and the will's not there. It's just that we have to be willing to say the way that we use our resources that are limited needs to change and evolve. And the way that we have communication or statutes or mandates or whatever it is, policy, protocol, et cetera, has to evolve because we keep having missed opportunities.
And I completely agree with that. As in primary care, one of the things that I always tell people is most of my daily job is either addressing two issues, obesity or mental health. And of course, there's other stuff that I still do address, but mental health has become such a significant aspect of not just our healthcare, but also just what we see out there as healthcare physicians and providers. Behavioral therapy, access to mental health services, they've become so limited. I feel like not just in Oklahoma, but even if you're just looking across the country. But what I think a lot of times is often understated and underemphasized is how mental health affects us as our overall health. So how does untreated mental health affect physical health, relationships, and just the overall quality of life?
So there's a ton of research around this topic in particular, and there's a lot of people who speak about it all over, internationally even. And we know that if somebody is struggling with untreated or misdiagnosed or inappropriate treatment for mental health, behavioral health service supports and needs, if all of those things are not at the level that they need to be, it definitely impacts your physical well-being, your ability to relate to others in healthy ways, your ability to discern, reality and boundaries and interactions with others, maintain employment, maintain education opportunities, housing. Relationships are, significantly impacted of not just romantic, but like all types. Your parent, child, yourself with your siblings, friendships, etc. We also know that there's a lot of compounding, like you just said, physical ailments and health that gets either ignored or treated as a last resort, like in an emergency setting, because your body's yelling so loud that you have no choice. And so it really is kind of that foundational building block that you have to understand. Like your brain has to be well. That means you have to be balanced. That means you have to have the supports and resources and interventions that you need so you can function. And it has to go hand in hand with your physical well-being. So all that preventative medicine and stuff like that. And especially working with some of the seriously mentally ill. And when I talk about mental health, if I can, I talk about it on a continuum
Mhm.
when I do these trainings. And so a lot of people talk about mental health, mental illness, and they interplay between the two. And so mental health is for everyone. Everyone should have the ability to focus on their overall well-being of their mental capacity and abilities and all of the things that they need. Mental illness is that continuum. That goes from individuals who do absolutely monumental things in this world and live with a mental illness. They, every day, all day long. So please hear me when I say it's wonderful when it they treat it and it's great and they manage it. Then it goes all the way through that spectrum of individuals who might need some additional supports and services, and they might cycle and they might have some additional needs, all the way to those with serious mental illness. And those are the individuals who have substantial interaction, typically with institutional settings, justice settings, really substantial difficulty maintaining some of those life things like we talked about, employment, housing, relationships, etc. And then we have that tiny piece at the end, and those are typically like your anosognosia people, serious mental illness who don't have the insight and ability to care for any of those interventions. And often, they are the ones historically who would be in like those long-term placements and things like that. We don't have that anymore. And so oftentimes that group is who we see on the streets or incarcerated, unfortunately. And so when I talk about the gravity of that spectrum of mental illness, typically the further we get towards the serious cyclic kind of thing, the less likely they are to have appropriate medical care for, not even just preventative stuff, but I'm talking about, I see often where they forget that they have, high cholesterol, they need insulin, that, there's that distrust in taking medicine, things like that start happening. And then also dentistry. There's an absence of oral health, and we know what
Mhm.
happens with the oral health, and so it's just kind of that overwhelming, gravity of, inattention or ability to actually attend to those or trust those systems to help you. And so that's why I say it's hand in hand. If the more ill and untreated and misdiagnosed, the more opportunities you have to be, institutionalized, justice impacted, et cetera. But also the further you fall away from standards of care of your physical well-being.
And thanks for throwing in dental health over there, because that is an episode that we're actually going to be tying into later on this podcast down the road. But, you've already kind of touched base on this just a little bit. But in your experience, what would effective integration between mental health and community organizations, hospitals, schools, what would that look like?
So I think we have to have those critical opportunity kind of look backs at what have we done thus far, how has it either benefited, where are the gaps, and really do kind of that gap analysis and be vulnerable enough to say like we missed the mark. Or we don't have the right people in the rooms. A lot of times you have great intentioned individuals who get groups together, coalitions and task force and all of that. And those are great. But what's often lacking in those group formations are people who actually know how to do the jobs. You get a lot of stakeholders and a lot of people who, study and kind of do all of this research and policy work, and you need them. But then you forget the people who have the mud on their hands. You forget the people who really do see the day-to-day opportunities and the day-to-day, barriers. We oftentimes, we create these policies or structures or standards, and everything that we're talking about right now, integration, it all exists on paper, right? It all exists on paper. The problem is it doesn't exist in the real world. It's not applicable for use in the real world. And so what happens is it creates unintended consequences, faux barriers, etc. And so for me, when I go in and help a health system, for example, take a hard look at integrative opportunities, the first thing I ask them is, what are your policies? Okay, let's look at the fundamentals. Now, can you explain to me how this actually works in real life? Because that's the first aha moment, is that people realize whatever the structure is that they've created with the best intentions, it doesn't actually work, because there's other things that happen in the field that the people making the decisions or drafting don't have any insight towards. And so I think that's the critical piece, is looking at what we have and asking those vulnerable questions and asking who's missing in the room to tell us what really happens on the floor. So that's step one. I think the other thing that we talk a lot about is parity, right? We talk about parity, and we there's laws that protect it, and we need to be doing it, et cetera. But again, it goes back to parity at what level? What does parity actually mean? And you have a lot of interpretations of what parity is when it suits the system, instead of realizing that there's a standard of parity because these things are equally important and they work hand in hand. Behavioral health physical well-being, and physical health systems. It all works together. And if it doesn't, that's where we see the gaps and the problems. And people don't understand, you always hear about cost savings and whatnot. It's not a cost saving to shift somebody out of a system to a higher dollar system. Emergency care, jails, things like that they're not an effective use of resource. It's a redistribution of resource. And you're using it in a way that's causing the most significant harm to the person and the community at a substantial consequence and a higher dollar for that, widget of service, for example. And so it's about really mapping the system out. And again, we can't solve all problems immediately. Like that's unrealistic. But
Mhm.
I think we have some fundamental things that are there. Again, parity law is one of those examples. We also have a lot of, initiatives in different communities and different counties, states, et cetera, that talk about that integration, right? Like there's task force and committees. And again, great intention, great, principle behind it, but you have the wrong people in the room. You're missing some folks. And so I think that's step 2 is getting people in the rooms who actually know applicability. How do these things actually function? So when you create this policy B, for example, how does policy B translate all the way down to client care? And what are the barriers and what are the opportunities? And so really doing that critical look is important. So
Well, I'm one of those people that believes, and this is kind of the whole point of having this podcast connected by health, which is that we as a nation and as a healthcare system haven't really done a great job of investing in healthcare and specifically in mental health. And I do believe that we need more support from the government in terms of putting together more resources or creating a conducive environment where you can have increase mental health coverage, and also increase the number of providers that are trained in mental health. For example, and I think if I remember correctly, 77 all 77 of Oklahoma's counties are designated as mental health provider shortage counties, which is kind of frightening if you look at the bigger metropolitan areas like Oklahoma City and Tulsa. How do you think local governments can better support mental health awareness and innovation and early intervention?
So I will say I've bared witness to a legislature that is absolutely supportive of this and taking a critical look. And like you said, they're looking at workforce. How do you develop workforce? How do you develop those providers? How do you change those statutes? That for example, how do you get more nurses in the field? How do you grow more nurses in education? Taking a look at the bachelor's degrees, looking at all these different levers that we can pull. And absolutely, we have a provider shortage. And more alarming than that is the providers that we are the most short are psychiatrists and psychologists. Those are your higher end, more adequately trained to address these really complex things that often get under, represented, misdiagnosed, overlooked, et cetera. And so I think we need to carve that piece out. And yes, I know there's some great movement from some of our universities to grow psychiatry and fellowships and opportunities. We need that same energy around psychology. And we need more psychologists with specializations, whether that is in forensics, whether that's in pediatrics or crisis or whatever. Specialization matters. And I think that's one of the opportunities that we have here in the state is
Mhm.
not only grow general providers, but we need specialists. We need
Yeah.
people who can really specialize in these very, very complex things. Crisis psychiatry, that's a whole specialty. And if you don't do crisis right, you're just going to say, see you soon, see you soon, see you soon. And every time they cycle through, you're just going to see a messier bundle of symptoms, a more substantial social impact, a substantial trauma impact, and a more pronounced illness as it goes forward. And so I think, again, provider shortage is a big deal. One of the things that I've always talked about is, yes, we need an infusion and an investment continuously and realistically, but we also need an accounting of what has happened. Because that is, I mean, you turn on the news, you see that everywhere where there has just a reckoning happening. What has the money gone to? Where is it being spent? And how is that return on investment being measured? What's real? And so, when you look at, here in Oklahoma, for example, we have the provider shortage, but we're also an early adopter of the CCBHC model, that community model, right? That certified community behavioral health clinic model. And that is a great model. We were the first in the nation to adopt that. The problem is that we didn't adopt it with the solid infrastructure that it needed from the state side. And so you have, discrepancies in care quality, discrepancies in data collection, and some of those things. And so, okay, that's a natural byproduct of a demo. Now we're in maturation. Now we need to take stock of what actually is being funded and how we're doing it, because the providers are blanketed across the state. Now, do they need more? Yes, absolutely. Do they need to grow? Absolutely. But what we need to focus on is how we're paying for them. What are the unfunded mandates? How are we capturing the data? And what is the data telling us about the intention of the model, right? How do we make this thing that we've invested in work at an optimal level? And how do we get a true accounting of that return on investment? And so again, it boils down to a few things. Data collection. We need a standardized data collection. We need to be able to synthesize that data and have outputs and figure out what it is that we're aiming towards, right? Instead of just throwing stuff all over the room, we need to be able to make sure we're hitting the basket, with whatever we're trying to do. I think that's a big deal. And that focuses too with the mandate of integration. What are those clinics, those rural clinics that are, struggling or functioning or whatever? How's public health factored in? Public health agencies all over different counties and whatnot. How are those factored in? Hospital systems. I mean, there's so many opportunities for us to sit and have those critical questions, conversations about this stuff. The problem that I know, again, I used to run these hospitals, that I run into oftentimes is that you have the payer source telling you, you guys can't be paid for the same service, even though it's uniquely different on the same day or something like that. There's all these weird caveats that are carved out that mandate things that aren't practical. And again, so, I'll just use an example. If you have somebody who comes into your hospital system, psychiatric hospital system, who's autistic, who also has a serious mental illness, so you're there stabilizing their medication and all those things, but they could benefit from, let's say, some type of other intervention. But guess what? Your hospital's not set up for that, but you also can't bring that in because then they can't bill because they're at your hospital. And so you're only treating a section of the person. And so I think we have to have more flexibility around how we treat somebody. And again, no one can be everything to everyone. And it's really about how you create those partnerships. And again, beyond paper, beyond policy, in practicality. Like, what does it actually mean? And does it translate into improved access, quality of care, and integration? If the answer is no, you shouldn't be partnered.
Well, I do not disagree with that one bit at all. But I think one of the things that I really wanted to touch on today and is the concern about a stigma that's still associated with mental health. I do think society today is better than it was a few decades ago, but we still do see this. What changes would you like to see mostly in how society talks about in response to mental health challenges?
So I think you're absolutely right. There is still a stigma. There's a misunderstanding, a misconception, but I have seen substantial progress. And this is coming from our youth. Our youth are talking about mental health and reaching out and leaning in and being more vulnerable like no other generation before their time. And I think that is promising. We're seeing more of these resources being, shared on social media and TikTok and Snapchat and whatnot. At the same time, though, we have more demand for mental health interventions and services and trauma exposure and the world. So it's like, at the same pace, and it's alarming. The other thing that I think we need to address around stigma is we can't over sensationalize it. And I think that's one of the things, unfortunately, that we've seen in some pockets is that some of the efforts to destigmatize have actually just been, tone deaf or offensive or just about the glitz and the glamour. And we have to remember our core function of why, systems and funding exist. It's to actually serve the person. And so I think it's really about how do we carry a message, and it's not even a uniformity of message because there's so many nuances and communities and cultures. And, I mean, I'll just use an example. You can't go to rural area and use the same message as you probably can in like a metro area. And so just kind of keeping that in mind is what are the methods that these individuals get their news, their communication, and figuring out the recipe there, I think is step one. The other thing is making things accessible. But the biggest thing is parity. We have no real stigma around going and getting a broken arm fixed. We don't have stigma around, I'm having a heart attack, I need to go to the emergency room or whatever. We don't have stigma around that. It's perfectly normal and acceptable. And if you didn't go get it, people would go, what's wrong with you? Right. And so I think that parity is that door
Hmm.
for us to really bring in behavioral health to that level of access, expectation, and acceptance. If we see them together and we make that normal, then it becomes the expectation. And you don't know if they're going to this service, if they're going to get their arm fixed or get, high blood pressure addressed, or if they're getting therapy. We don't know, right? Because it's so normalized and integrated and together. And I think that's the opportunity, the big opportunity. Obviously, there's going to be a lot of work around this because fragility is a very difficult thing to talk about. Vulnerability is a very difficult thing to talk about. And we tend to think that when someone is struggling with a mental illness, that they're broken. There's a lot of people who still think that, and that's not accurate. They are just in need of some supports and interventions, just like you would if you had diabetes, just like you would if you had asthma, and so I think it's that reframe.
And I really appreciate you stating that part about how we need to reframe that aspect of mental health. It's just as if you're getting treated again for something physical, except this time it has to do about your mental health, right? Like when you talked about getting treated for diabetes, getting treated for hypertension, or even just getting treated for a broken arm. And that's the way we need to look at it. One of the things that I am quite familiar with is the Psych D degree that you have gotten. And
Mhm.
I actually didn't really know about it until just a few months before I went into medical school myself. But I was wondering if you can tell us a little bit about what the Psych D program is for those of our audience that are not familiar with it.
Yeah, absolutely. So when I was going to school, hasn't been that long ago, but it really has. It was one of the newer degree programs, and the way that the school that I went to really divided it up, there was the PhD program and then the PsyD program. And so most of the folks that were going to, not all, but most of the folks going to the PhD program, they were going into research and those types of policy types of roles. The folks that were in the PsyD program absolutely knew they wanted to practice, that they wanted to go into the direct service line of field. And it doesn't mean there's not overlap. We had a lot of the same classes together, a lot of the same fundamentals. But that's at the time that I was going to school, that was really how it was divided up. It was those that knew they wanted to do research and teach, and those that wanted to do direct practice. And so that's kind of how it was divided up. Similar core, similar spine between them. More emphasis on diagnosis and evaluation on the PsyD side, whereas the other side was more emphasis on research and methods and those types of things above the spine, if that makes sense. And so when I was going to school, at first, I knew I wanted to do psych evals. I mean, that was kind of what I was drawn to. And so I had a great professors and whatnot. And so I went down, that side of the hallway, if you will, and it said forensic, PsyD. It was like the sign above the door was like, come to the dark side. We have cookies kind of thing. It was a joke because we dealt with some of the most complex diagnostic, issues and situations that a lot of average people didn't look at, didn't know existed in the world. And I thought that's what I wanted to do, honestly. And I did. I loved it. Worked at special case investigation unit, did forensic evals and all that great stuff. But then I had a fantastic supervisor who gave me an opportunity to do an administrative launch of a massive program.
Hmm.
And once I did that, I realized that was my calling. So I went back, got an MBA and did the whole thing and became that administrator systems person, and it doesn't mean that I don't still get drawn in on some things, but that's not my lane anymore.
I feel that people only in the healthcare field are really familiar with, but the general population is not really able to differentiate between the two. And so thank you a lot for making that clear. Let's talk about your book, and I'm really excited for this, especially the book is entitled Obedience for a Paycheck.
Yes.
Just curious, what made you want to write this book?
So it's really about the indoctrination that occurs inside toxic work cultures. And I think we've all experienced one or two in our lives, right? Especially the older that we get. And I, lived through it, but I also have worked with a number of people independently, contract or even agencies where they've discovered that there's some toxicity that's going on. And so sitting there thinking about how does this come to be? Because it's not typically one person, it's not typically overnight. And then, what do you do if you're in it? And so, really sitting down and thinking about the three structures that emerge in a toxic kind of indoctrinated work culture. You have one pocket of people who either knowingly or unknowingly kind of perpetuate it, right? Because either they believe whatever that toxic structure is standing for, believing in, pushing forward, or they're doing it because it's an opportunity, right? So they're like doing it and playing along, going along just to get, opportunities. Then you have those in the middle, which are your individuals who typically trade opportunity for safety. They keep their head down. They just kind of status quo. They don't make waves. They know something's off. They know something's wrong, but they just don't feel either empowered or able, or they don't want to risk it. They're just kind of like, hey, it's a job, whatever. I leave at the end of the day. It is what it is. But they also don't get opportunities. They're not getting the promotions. They're not getting the special projects. They're not getting anything special. And then the third pocket of people, those are typically your disruptors. Those are the ones that notice that the mission isn't matching the actions. They're the ones who start going, why does this feel weird? Why is this not working? Why is this, and so they start asking a lot of why. And that population of people typically start taking notes, start asking questions. Pretty soon they start getting isolated, removed from opportunities. And a lot of times they'll either get squeezed out or retaliated until they give up. And so it's really about how all three of those happen. And then what do you do if you're in each of those buckets? How do you overcome, recover, break that cycle, whatever, depending on which bucket you're in. And then there's a piece in there about if you're a system who's recognized that this has happened within your system, how do you take stock and start having those foundational pivot moments so that you can stop it? And so that's what the book's about. I have a number of books that are kind of slated to come out over the next year or so, some fiction, some nonfiction. And so it's really been a great opportunity. I've been wanting to do this for a long time. I'm super creative. And so I just thought, hey, this is book one. It's meant to be a short read on purpose because I don't want to overly saturate somebody. Because if you're picking up this book, odds are it's for a reason.
Mhm.
And I don't want to overly saturate an already stressed person. And so it's really about this is your moment to have, that reflection, that clarity, some tactical things and some reflection.
Mhm.
And so that's really what the intention of the first book is.
Wow, a couple of books. That is highly impressive. I don't know where you find the time or the energy to put all this together because it is not an easy task. And so, eagerly looking forward to Obedience for a Paycheck, but also for all your other works in the near future. Any words of wisdom for any of our listeners looking into going into the mental health field? Or into what you're doing about leading systems and changing systems for the better.
Yeah, absolutely. So if you are thinking about going in the mental health system, we need all types. We need everyone from, peers and peer programs and peer recovery support systems all the way up to integrative, specialists and archetypes and all the various specialty, in between. So psychiatrists, psychologists of various types and therapists and social workers and nursing and everything in between. And we also need people who have the mindset of integration and that are willing to kind of be nimble and vulnerable and do something different than what it's always been done. We have a lot of things that are working in our favor right now. We have collaborative care models that we've been talking about through SB 444. We have, a lot of integration happening within certain private agencies that are already taking those big, bold steps to kind of collaborate with primary care and physical health structures and dentistry and pharmacy and all sorts of home-based services. We have, like I said, the CCBHCs. We have all of these things that are moving in the right direction. We have 988, which is funded now. Now that we've kind of crossed that funding hurdle, now we need to look at, again, metrics and how 988 actually functions. What's the return on investment? Those types of things are really important. We have a federal consent decree that Oklahoma's in right now for competency to stand trial for those that are seriously mentally ill in the justice system. And that system's getting a revamp. And so I think there's so many opportunities. We have the Physical Health Care Comorbidities Act. We have the parity that we talked about already. So there's the wide open range of places that people can get involved within the behavioral health system it's never been this big. It's never
Mhm.
been this wide. It's never been this big. So I would say, jump in, find out what your niche is. Don't be afraid, and don't get comfortable, and don't silo, don't click up, don't do the things. But I do have, a wish list if I could. One thing we obviously need to talk about is we need to stabilize ODMHSAS financially, structurally, clinically. I think that's been in the news, and I think it's not a secret by any means.
Mhm.
Hopefully, we'll be heading towards that. I think we need to protect the CCBHC model by fixing that data level and that layer, standardized definitions, reporting across clinics and systems. I think we need to talk about the outcomes, the return on investment, the way that we fund it, because it matters. We need to know what that return on investment and how we can, again, continue to evolve. It's not a one and done. I think that we can expand our mental health and specialty courts across the whole area. I think we need to look at those existing physical health and clinic systems and hospital systems in all the areas within our state, the rural areas, and figure out how we can integrate in real meaningful ways. I think the other thing, we've talked about it, but we need to move it forward, is our Medicaid, our 1115 waivers,
Mhm.
specific to reentry and incarceration. That is a huge opportunity that we have not completed. We have a lot of individuals who are in the justice system, either in local jails, county jails, or in prisons, and they're reentering our society. And if we have done nothing to assist with that other than a piece of paper, go here, go there, we have given them, and I just wrote an article about a scavenger hunt. That's what we give people when they leave institutions, is a scavenger hunt, and then we wonder why they fail. It's because it's too complex and they're not structured and situated to be able to carry that out. And so I think 1115 waivers are a big opportunity for us specific to reentry and incarceration. I think we also need to which we have a lot of momentum around state question 780 and 781, getting that uniformity and standards of data reporting so we can really capture what cost savings looks like, so we can reinvest that within those counties for justice systems and justice involved prevention types of things.
Mhm.
I think we need to integrate our intellectual developmental disability systems and our behavioral health systems as a massive gap. We need to close the statutory and agency gaps. And that's easy to do on paper, but it's going to take substantial effort and great leadership to do that. But to do that, you would have a lot less people in shelters, you'd have a lot less people incarcerated, and you have a lot less people living all over the place on the streets or wherever they can live that fall into that specialized little bucket there. And this is another big one. Bring our children home. We need to evaluate what Oklahoma spends on exporting our children to placements at levels of care that we don't have internally. We
Mhm.
have a lot of kids with complex diagnosis and complex behavioral challenges, and we don't have the level of care or the available beds. And so we export them to other states, therefore transporting them, away from their care support systems, displacing them from their communities. And we're also giving our money to another state. And what we need to do instead is take that same money and invest it to build out our behavioral integrative structures within our own state. I think that's a big deal.
Mhm.
So that's my wish list.
Well, that is a terrific and a very, very concrete, detail-oriented wish list, and we cannot thank you enough for sharing that with us. Really appreciate you coming on, Dr. Hernandez. And so, for all of our listeners, we had Dr. Hernandez here today, who has done an amazing job talking about behavioral health and the challenges that we're looking at mental health here in the state of Oklahoma. Now, don't forget, she is a forensic psychologist by training, but she is also becoming now a system architect and an activator. And remember, to all our listeners, this is Connected by Health. This is your podcast, because at the end of the day, we're all connected by health. Thank you so much for listening today. And once again, Dr. Hernandez, thank you so much for being here today.
Thank you.
And folks, we'll see you again next week. If you found this conversation valuable, share it with someone who could use it. And if you're on Apple, we'd love to hear your favorite takeaway and a review. See you next week.